Thank you so much for the nice introduction, Ashish, and a very big thank you for the invitation. It's a real honor to be here and a pleasure to be in this historical building together with you. So yes, let me speak for a couple of minutes of how we see the role of digital in global health. In fact, the challenges in global health have never been as big as they are now. They are unprecedented with the rapid urbanization and the increasing inequities that brings. The unfinished agenda of infectious diseases, mother and child health issues, and the constant threat of new diseases, with at the other side of the crossroad this rising tide of non-communicable diseases. While we know that health systems around the world are very much insufficiently prepared to address those global health challenges nowadays, let alone by the shortage of skilled health professionals in the world. If you look at the map of the populations per doctors in the world, it's very unequally divided. So, given those challenges, this calls really for innovating the way we deliver health services, for transforming our health systems. As Ashish rightly says, we cannot go back to the old model. It doesn't work. We shouldn't continue that way forward. So let's look at how we can reimagine the way we deliver health services. And to do so, what is the best method we have currently, the best opportunity we have currently? Digital, of course, digital and AI. That's how I also see it personally, because I'm very passionate about digital health because of my history. In fact, I began as a young doctor, very idealistic, working as an emergency physician in conflict areas with several organizations and ICRC, as Ashish said. And I was dropped in some countries in the middle of the guerrilla areas in the bush with my bicycle, going from village to village, looking after the patients that health workers were keeping for me there. So you can imagine sometimes I had quite a dangerous route to go with my bicycle on my shoulder, crossing the rivers between the crocodiles. No crocodiles. But sometimes pretty amazing journeys. And now I couldn't have dreamt that nowadays you can do that job simply by phone. Because you can coach unskilled health workers on the ground by phone and help them manage their patients through the telephone, and it works. This is how we did it, for example, with our Novartis Foundation now in Ghana, where we tried out this very simple telemedicine model, connecting community health workers, health nurses in the health centers remotely, by phone with skilled health professionals in the regional or referral hospital that was a teleconsultation center staffed 24/7 by doctors, experienced midwives and nurses. And we have the results of that pilot, if you may, in the region of Ashanti were so impressive that the government wanted to scale this model nationwide. And I'm very proud to tell you that now, since last year, this telemedicine model, very simple, and now, of course, added of WhatsApp and images and many other tools to improve it, has now become the national telemedicine service in Ghana, covering more than 7 million people. And this is how it works. 70%, 70, of all the problems could be solved by phone. So no more bicycle rides through the bush needed. This is also how we approach things in the Novartis Foundation, starting with an innovative model of how we can reimagine the way health services are delivered. For example, with digital as the glue between non-traditional health players who can play a very significant role in healthcare. We use shopkeepers, for example. We train them to measure blood pressure, to measure risk factors for high blood pressure or cardiovascular disease, and train them to give the right information to people who screen positive. Shopkeepers from barber salons, manicure salons, bus stations, post offices, any kinds of shops you find on every corner of the street in Africa who sell lots of stuff. Shopkeepers can be instrumental in detecting early high blood pressure, for example. These pilots, which we did in Ghana and in Ho Chi Minh City in Vietnam, first at a small scale in Ho Chi Minh City, we lost our patients and we went for the entire city immediately, have read out now. In Ghana, the smaller one has read out. Results are very inspiring, 80% of blood pressure control rate with a very high increased detection rate, I would say. The coverage is not perfect yet because you come from 0 to something, it's already that. But in Ho Chi Minh City, for example, the government is not even waiting to see the data. They took it up. The Ministry of Health has made it national policy to include social enterprises and other enterprises into their health system because they play that role thanks to the digital system that is the glue. Every positively screened person is immediately referred to the health system by digital so that the community nurse or the health center personnel know who to follow up for diagnosis and treatment. And this works really well, thanks to this fantastic opportunity of digital. Then when we scale a program like that nationally, we hope that governments translate it into policy. That's our approach. And we can only generate as much evidence as possible to turn to the government and then tell them, here's the track record. Now you can scale it. But that takes a hell of a lot of time. It takes between 3 to 5, sometimes 7 years to get there. So we lost our patience and started to work at scale immediately. And that's how we started our urban health initiatives currently running in Sao Paulo, Dakar, and Mongolia. But I'm not going to expand on those. We translate these innovative models there at citywide scale. But sometimes we even manage to translate policy for global health and global health policy. And specifically in the area of digital health, we were very successful in that way, in the sense that I had the pleasure and the luck to be part of the Broadband Commission for Sustainable Development, where there's all the telecommunication magnates, the CEOs of the IT companies, ministers of IT, ministers of education, ministers of health, all around the same table. And I'm chairing the working group on digital health there. And with that group of world-class experts from private and public sector, we developed 2 major research and stakeholder consultation documents on digital. The first one looked at case studies across the world of how governments can realize the full potential of digital health. And this dates from 2016, but we looked at countries ranging from Canada to Norway to Estonia, of course, the gold standard Estonia, to Rwanda, Mali, Nigeria, even Malaysia, Philippines. And each single one of these case studies showed us that there is 3 success factors necessary for a country to realize the full potential of digital health. And they are the same, regardless of the resource level of the country. The first one is you need committed government, visionary, committed leadership in the government who also commits financing to digital in the government system and specifically in the health system. Secondly, you need intersectoral collaboration. So it's not a given that ministers of health will talk to ministers of IT or ministers of finance or even know about each other's needs and offers. And I learned yesterday at the dinner that that's not specific to governments. In fact, I hear it's also the same in academia. Bringing multidisciplinary teams together is not always obvious. And I can tell you it's the same in private sector. In our urban health initiatives, we try to bring multidisciplinary private sector players together to address the underlying determinants, like getting healthier food options, better exercise facilities, better urban planning, and then strengthen the health system. Bringing these different agendas around the table is pretty difficult. So it is not specific to governance, but if you don't have that, it won't realize its potential. And the last success factor for digital to become really integrated in a health system is, of course, that you have a national IT framework that sets the standards for interoperability, but also for regulation and legal frameworks. The second consultation we did was specifically about how digital can improve the way non-communicable diseases are addressed in low and middle income countries. Because you know, health systems in those settings are very often geared towards acute care alone. So they don't know how to handle the needs of chronic patients. Therefore, digital is the perfect tool to make chronic care available to many more people. It empowers not only the providers with clinical decision supports and all the other things we know, it empowers the patients themselves to take more responsibility in managing their own health, and it empowers the policymakers because they can make their processes more efficient. And we came to the conclusion in that one that in fact digital should become an essential part from every health system. It shouldn't be considered as a separate part of the system anymore, because then it's not even included in the budget very often. It is as essential as hospital beds are, so it has to become part of every health system. To become sustainable, however, we also saw that solutions have to be fully integrated in the health system, and that's the same what Bernardo was saying at WHO. If you need digital to become integrated, it has to really fit into the existing system. It shouldn't be creating a parallel system. And maybe that sounds obvious, but that's what happened on the ground. We saw so many different well-intended solutions that never made it to scale because they were not integrated into the health system, not responding to the priority needs of countries. Secondly, of course, they have to be scalable, and scalable solutions are those that are the simplest ones. The one I gave you the example of telemedicine, very simple model. That's why it was successful in becoming a national model. You have to use the infrastructure that is available on the ground. So we use the normal phones of health workers that everybody has in his hands. And lastly, of course, they have to be financially viable. But we believe that for AI, the similar requirements occur, and because AI also has to be completely integrated into the health system, you cannot build a parallel system to existing infrastructure. It has to be patient-centered, person-centered. You include the end user in your design or it will fail. If you don't take all the things that people who will use it need into account, it won't get there. You need to know the local context and obviously base your algorithms on adequate data. And that is an easy word, but a very difficult task. Because data in low and middle income countries, just like in our countries here, are buried in standalone silos, are very rarely interoperable and speak to each other. So this is maybe in some low income countries an opportunity where there are no digitalized data yet, to overcome that silos are created, to create interoperable systems immediately. And lastly, Ashish already mentioned all the challenges we will have to discuss today. I won't go through these in detail, but I think we come to them the whole day. So let's focus on how AI is only starting its journey, in fact. Even in high-income countries, it's beginning to get an impact on clinicians, all of us using it specifically for image recognition, for example. It's proven now for many aspects to be more accurate than clinicians or more fast than clinicians. It's also improving processes in health systems, can even monitor epidemics, which is very interesting in public health, obviously, and it helps patients to empower them to take more responsibility in their own health. We think in low resource settings, in fact, the advances I mentioned throughout the rest of the talk, the digital technologies that were brought into those countries have set the basics in place so that AI can now come on a better field than in high-income countries, because there's not this huge backlog of data to count with in every setting. On top of that, there's been increased broadband connection, increased coverage of mobile phone penetration and mHealth applications, really substantial investments in digitalizing health information systems and in cloud computing. So there's a very big opportunity for AI in low-income settings. But again, the challenges remain. We need answers for privacy, security, transparency, fairness, accountability. Everything related to the data has to be really clear, set in some kind of rules for patients to be safeguarded of all these risks. And then, is it true what the title of our event says today? Do we have more hype than science? Well, many of us believe so, because there's very little prospective validation yet of algorithms and of AI solutions. So we should really look at that, because everything we have is based on the retrospective data from electronic health records and other things. So we need to validate our tools proactively. And lastly, I think one major risk we run is that we exacerbate inequities that already exist. If we use data sets that exclude some populations, we will include a bias, and that is absolutely to be avoided, obviously. And then, if we make a mistake with an algorithm, it's worse than if it's a single doctor making a mistake. So this we should also take into account. Let me end with a word on how we now are using AI in global health proactively throughout our work on the elimination of leprosy. Leprosy is the oldest disease we know, the oldest disease known to man. You may think it's gone. Well, it's almost gone. We've been working on it for 30 years and have reduced it by 99%. The problem is that the last miles to cover are the worst ones. We've seen in the last decennium that the number of newly detected cases stagnate around 200 to 250,000 patients. So we need to do something differently. We need to really interrupt the transmission if we want to get to real zero leprosy. And that's what we are currently doing with Microsoft. We just launched this partnership where Microsoft is developing an algorithm to accelerate diagnosis of leprosy on skin images based on a tool we validated in the Philippines, where remote health workers could send their image to reference dermatology centers and get an answer back, yes, you should refer, or please start treatment, or no, this is absolutely not leprosy. That tool was validated, and with the simple reference doctor, reduced the time to diagnosis from 100 days to 2 days. So with this algorithm, we hope to make this a consumer good, that anyone can send an image and get a probability back from the cloud. What is risk is that this is leprosy, and with that, accelerate diagnosis. This is happening in Fiocruz, where we do a clinical trial. Fiocruz collects the high resolution images, couples it with the metadata of the patients, and then Microsoft builds the algorithm on that. So that's what I wanted to tell you about our story and how leprosy has become a center in the new healthcare paradigm, which has to become, instead of reactive, preventive, predictive, personalized, continuous, and coordinated. So thank you very much for your attention.
I just want to see if there's any quick questions or comments. I know we're about 10 minutes off our schedule. We will catch up. No, you were fine. I was late.
Okay.
So any questions for Anne before we move on to our flash talks? We do have a microphone, so we even have that. Anyway. Yeah, please. We will
perfect. Now. Okay. Thank you. That was absolutely wonderful. I have a question with regards to, as you roll out a lot of these technologies, especially, at the national level, are there any ongoing efforts of collecting this data for research and kind of improvement of these, methods?
Definitely, yes, a very good question, very important. We always measure what we do. We come from an evidence-based company also. So we did collect the data on these innovative models and how it improves the patient outcomes. Most of them get published or are published already. The ones that are not yet are coming out. But on the data for specifically at national level, it will be the national data that will show whether it works also at a national level. We measure it at a smaller scale, just because of the size of the problem.
Is there any talk of potentially making such data accessible to, the research academic community in a de-identified way, or?
Definitely, we can think about that, and it is already accessible in the smaller scale where we did measure. It was always with academic partners, so we can definitely think about that nationally, how we could make that work. It's a really good question.
I think we have time for one more. Yes.
Hi, I'm Kathy Pham. I was so excited to hear you bring up the idea that this can only really work if we are fully integrated into health systems. What are some of your thoughts on getting these people who develop the technology, the engineers, the designers, et cetera, to really understand how to really fully integrate into these regions that they probably will never visit or they will never see or have or really experience?
I think that's the real essential question. Bringing the IT technologists together with the health specialists is absolutely key, and that's how you should always start to discuss it, because it has to be co-developed from the start. If it doesn't, you will have very big difficulties to integrate it in a second stage. You have to do it from the beginning. So we try to bring them around the table from the beginning and build it on the existing infrastructure, but both from the health side and the IT side. And just for clarity, it's not the Novartis Foundation doing that. We would always call upon an IT partner because we won't be building IT capabilities ourselves. So we did this with Intel. Now the AI tool we do with Microsoft. So we always have an IT partner when we implement these things, yes.
Thank you, Anne.
Thank you so much.
It strikes me, as we've been hearing this morning, the whole idea of digital health reminds me a little bit of about 20 years ago, we used to talk about e-commerce. We don't talk about e-commerce anymore. We just talk about commerce, with the idea that E is kind of part of the way commerce works. I think if we're going to move from digital health to just health, with digital as a critical platform, then we have to sort of do the integration that you described, so that we're not talking about digital health, we're just talking about health with digital as a critical part of it.